So when do you remove the cyst?
Okay. As a general rule, we try not to remove cysts. Generally, all cysts, nothing to worry about. But if it's an ovarian cyst, you have to pay a little bit more attention to the nature of the cyst. Breast cysts do not need to be operated on. Breast cysts cannot be biopsied. If you are stage 4, then obviously your chances of cure are rather poor.
So when do they need to go for a second opinion?
Okay.
Do everybody need a second or a third opinion?
That is a very, very difficult question to answer.
Okay, we have a very special guest today, Dr. Peng Tiam, who is my doctor, one of the leading oncologists in Asia. Dr. Ang, a lot of my patients, they come home, they see their ultrasound result and it has breast cysts, kidney cysts, ovarian cysts. So can you talk about some of these cysts individually?
Of course. So a cyst is basically a collection of water. Okay. Most of the cysts are non-cancerous. So the only one that you have a little bit concern is when you talk about an ovarian cyst. In an ovarian cyst, it's very important for us to look and see what is the wall of the cyst like. If it's a thick wall cyst and a thin wall cyst, is very different. A thin wall cyst means that the wall of this particular cyst is very thin, and then these are generally benign. But if it's a thick wall cyst, then you have to be a little bit more concerned, because sometimes in the wall of the cyst, it can be malignant. So again, by and large, most of the cysts that you're talking about, the cysts in the thyroid, the breast, the kidney, the liver, no concern. Ovarian cysts, you have to pay a little bit more attention to the nature of the cyst.
Ovarian cyst is very common, right?
Ovarian cyst is very common, and that's why it's important for us to differentiate the different types of ovarian cysts.
Okay. Can you expound more on what they will do? Because a lot of people have ovarian cysts, whether it should be operated, what is the algorithm to find out?
So again, generally all cysts, nothing to worry about. But if it's an ovarian cyst, often we say that it needs to be followed up. If it's a thin wall cyst, not really important to do anything. But it's a thick wall cyst, then you may need further evaluation. The simplest in actual fact is just to monitor it. You can monitor it in a 3-monthly interval, 6-monthly interval to see whether the cyst grows. By and large, cysts should not grow. Cysts should not grow. But if you have a thick wall cyst that's growing, then certainly you need to talk about doing blood tests to see whether there are any cancer markers that are raised. And then, of course, in the worst case scenario, you would talk about removing the cyst to confirm whether this is malignant or not malignant.
So when do you remove the cyst?
Okay. As a general rule, we try not to remove cysts. Because, breast cysts and so on, some patients can have 30 breast cysts. If you go and remove cysts, you're just trying to make money from the patient. So by and large, cysts should just be followed up and do not need removal. In a thick wall cyst that is enlarging in size, or a thick wall cyst that has got a raised cancer marker, yes, surgery should be considered.
So for those with ovarian cyst, sometimes they go to different doctors with different opinions, so it's confusing to them.
That's why it's so important that the ultrasound images should be compared with one another. It doesn't matter whether you're going to different gynecologists or not, but if you do, make sure they compare to see whether this thing is evolving with time. If it's something that gets bigger and smaller, no concern. If it's something that continues to get bigger and bigger, or the wall becomes thicker and thicker, of course these are of serious concern, and you must consider surgical removal to confirm that it is not cancerous.
Is there a certain size? Going to a certain size, you have to operate, even if it's a thin-walled cyst.
That is the odd part. There's no size. Some patients, in actual fact, can have very, very large thin wall cysts, and they have no concern, because these are not cancerous. So size in itself is not an indication for surgery.
Is there no danger when you poke or husband and wife?
No.
There's no danger it will...
No. No, even if it ruptures, it's not of great concern. It generally does not rupture. The human body is quite amazing. It knows how to protect itself. So the ovarian cyst, in actual fact, is not a fixed structure. It can often move around. But of course, if indeed the cyst is large enough to be symptomatic, okay, such that sometimes patients complain, oh, I've got frequency of micturition because the cyst keeps blocking the area, the bladder can't fully distend, and therefore they go to toilet very, okay, then you can have it removed. But generally, it is not an issue.
Dr. Ang, you have so much experience. Can you share how long you've been a doctor?
Okay, I actually started practicing, being interested in cancer in 1986. That's when I started my training in Singapore initially, then subsequently the Singapore government sent me to MD Anderson Cancer Center, one of the top cancer centers in the US. And from there, I moved on to Stanford University, where I trained under my mentor, Professor Saul Rosenberg. And then subsequently, I came back to Singapore. I eventually became the head of the Department of Oncology in Singapore General Hospital. And subsequently, I came back in the private sector. And now currently, I'm the medical director and senior consultant in Parkway Cancer Center.
So how come your treatment is sometimes different from other doctors? And I think from my experience, your success rate looks higher than others.
I think one of the important things is really the combination of knowledge and experience. As a young doctor, when you're trained as a medical oncologist, very often you are following a textbook. It's a cookbook. You just follow the cookbook. And this cookbook generally, 90% of the time is going to serve you very well, But it is true that over the course of time, you begin to learn how to improvise. And this improvisation comes especially when cases are more complicated. That's where you draw upon your experience of treating other patients to see how best to help this particular patient. And that is why that's the important difference I see between what a younger oncologist may do and what senior oncologists may do.
Thank you very much for that, Dr. Ang. So let's go to another topic about breast cysts. This is also very common. Is there a better approach for this? Because when patients go to different doctors, they get confused. One wants to operate, one doesn't want medical just management. Okay.
Let me be very clear. All right. Breast cysts do not need to be operated on. I say it one more time. Breast cysts do not need to be operated on. As long as you say the word is a breast cyst, no need to do any surgery. In actual fact, that's the main distinguishing factor. When we do an ultrasound of the breast, we distinguish between those that are solid lesions and those that are liquid. Solid, you have to pay careful attention. It can be benign nodules like fibroadenomas, all right, or it could be something more ominous like a carcinoma. But when it's a cyst, that one you rest assured. No surgery is required for breast cysts.
How about biopsy?
Breast cysts cannot be biopsied. Breast cysts can be aspirated. You can put a needle in. Sometimes patients complain of very painful breasts because the cysts are engorged. They're full of water. And many of these patients who come to see me, I don't even send to the surgeon because it's so simple. I just stick a needle, suck it out. If I want to be very careful, I send the cytology just to prove that it's not cancerous. But 99.99% it is not cancerous when it's a cyst. That's why it should not be operated. Now, if it's a solid lesion, that's a little bit different. You've got to look at the features of the ultrasound. Some of them are very clearly benign looking. They do not require any surgery. But if there's any suspicion, you can always do a needle aspiration to see whether they're cancer cells. This can be done very simply in the clinic, does not require anesthesia, nothing at all. And it's literally a 2-minute procedure.
How about the BIRADS staging?
The BIRADS is usually used, is more applicable when you're talking about the BIRADS on a mammography. That's not on an ultrasound. And that's often referring to the BIRADS of the solid lesions. Yes. Cysts, generally, we just say these are benign cysts. We don't give it a BIRADS rating.
So you don't say if it's more than this BIRADS?
Well, BIRAS is a general classification. 1 and 2 are definitely benign. 3 it needs further observation because of certain features. 4 is very suspicious. 5 is confirmed. This is mammographic screening. Okay, so it's very important in that situation to look at a mammography in order to determine whether further biopsy is necessary.
This is the difficulty of patients. When do they need to go for a second opinion?
Okay.
Do everybody need a second or a third opinion?
That is a very, very difficult question to answer. I mean, very often, a patient comes to see a doctor because he trusts. There must be a certain element of trust. Use yourself as an example. You came to see me, you saw me, I gave you an opinion, you felt that the way I presented it was logical and you were agreeable. I don't think after you saw me, you went for any second opinion. You came to me, you listened to what I had to do, you saw what I was doing for you. I mean, yours is a very classic case. You didn't go for a second opinion. And I think that we have worked well together as a team and we've been able to help you to get better.
Thank you so much, Dr. Ang. So, how about liver cyst? Liver cyst is also
again, liver cysts are benign. We often pick up cysts when we do simple basic ultrasound the liver. We find it. Don't do anything. It doesn't need to be aspirated. If you're concerned, just follow up over a period of time, 6 months, 1 year later, to see what is happening to the cyst. But cysts, as a general rule, I maintain are benign and do not require surgical intervention.
Even if the size is big?
Even if the size is big. I have got some patients who have got 10 centimeters cyst in the liver, but it's okay. It is still benign.
Okay. How about kidney cysts? Also benign?
Kidney cysts are generally benign. It's very common to see kidney cysts. Some of them are very small. They could be 1 centimeter or less. Some of them can be quite big. Some patients can have cysts of 5 centimeters, 7 centimeters, and yet we do not do any necessary intervention.
Another common problem we see with ultrasound is thyroid cyst. And thyroid cancer is also very common.
Okay. Again, we separate between cysts and solid lesions. Okay. Solid lesions, you have to seriously consider doing a fine needle aspiration. Cysts, you can leave alone unless they're ugly and they're causing this bulge in the neck that you want it removed, then you just aspirate it. And often you draw colloidal material, you can send it off for testing to prove that this is a colloid cyst. And then these again do not require surgical intervention.
How about other cancers, Dr. Ang, like colorectal cancer? I heard you gave a talk before on colorectal cancer.
I actually see a whole range of cancers. I see breast cancer, lung cancer, colorectal cancer. I see ovarian cancer. I see many, many cancers. I see lymphoma. Colon cancer is a very interesting cancer. Let me share some very important facts. Okay, 85% of all colorectal cancers start from a polyp, a colon polyp. Okay, and the time it takes for a polyp to become cancerous, if it becomes cancerous, is believed to be 7 to 10 years. So if you have a polyp and you just remove it when it's benign, you can actually prevent colorectal cancer. So that's why in more developed countries, they actually recommend that you go for colonoscopy once every 7 to 10 years. You find a polyp, you remove it. You've actually reduced the risk of colorectal cancer. Unfortunately, about 15% of colorectal cancers don't start from polyps. They just start from the flattened mucosa. And that one you cannot preemptively remove the precancerous lesion. Therefore, if you ask me, colonoscopy has made a big difference in terms of early detection of colorectal cancer as well as prevention of colorectal cancer.
What age would you recommend and how often for colonoscopy?
Again, I think the best age to start is at 40, and you can consider doing it once every 8-10 years. This is good enough. It's very important that you do a scope. You must see a doctor who is experienced in doing it, because it's very important that he must remove every polyp that he finds. Every polyp must be removed. All right. And once you have done a colonoscopy and you find that there's a polyp that you have removed, the next year you must go back again to do a screening again to make sure that there are no polyps. If there are no polyps, then your next scope can be 7, 8, 9, or 10 years later.
Okay. Any final advice for colorectal cancer?
Colorectal cancer is treatable. You know, the best thing is obviously you must try to do your routine colonoscopy so as to prevent colorectal cancer and to detect it early. If it's detected early or you require surgery, you don't require anything else. If your colorectal cancer is found to be stage 2 or stage 3, you must discuss with your doctor whether you require chemotherapy to prevent it from coming back. If you are stage 4, then obviously your chances of cure are rather poor, but still some stage 4 colorectal cancers can be cured. And that's why it's important that you seek your medical opinion from someone who knows how to treat colorectal cancer.
And the warning signs of colorectal cancer are?
Colorectal cancer symptoms are, could be anything, a change in bowel habit. If you are a constipator, then suddenly you find your bowel movements become very, very good. Something may be wrong. If you are someone who goes regularly, suddenly it doesn't become regular. Again, there's something wrong. So that's called change in bowel habits. The second is you start detecting blood in your stools. If you find some blood in the stools, it not necessarily means that you've got colorectal cancer. It could be something as benign as just having hemorrhoids or what we call piles. So blood in the stools is the second. Number 3 is if you start having abdominal pain, very unusual abdominal pain or bloatedness. So these are fairly common symptoms that you must consider seeing your doctor for evaluation.
Okay, thank you very much for this interview, Dr. Ang. Thank you so much.
Thank you everyone for listening in.